So I'm going to be talking about kind of a new spin on an old idea, specifically melflufen, also known as Melphalan Flufenamide, or the commercial name, which is now called Pepaxto. So I'm just going to walk you through the bottom half of this cartoon here. The top half refers to belantamab mafodotin, or Blenrep, which we're not talking about today. So melflufen, or Melphalan Flufenamide, is an alkylating agent, just like melphalan is, which is what we use at high doses in the setting of autologous stem cell transplantation. It's in the same family as cyclophosphamide, and in the occasional instance where bendamustine might be used to treat relapsed refractory multiple myeloma. So one important difference about Melphalan Flufenamide, which is a peptide drug conjugate, is that it's what we call lipophilic, in other words, fat-loving. This is important because the surface of a myeloma cell is made of a fatty membrane. So this lipophilic structure of Melphalan Flufenamide allows it to cross inside, across the membrane inside the myeloma cell quite readily. And then what you see over here is a bunch of little Pac-Men, or scissors, which are enzymes or aminopeptidases, which actually clip Melphalan Flufenamide once it enters the cell. When the scissors cut Melphalan Flufenamide, you have liberation of melphalan, actually. Melphalan is hydrophilic, or in other words, water-loving. Think about mixing vinegar and oil. It doesn't work out so well. So once hydrophilic melphalan is released inside a myeloma cell, it's kind of trapped in there. It doesn't exit the cell very well because, again, that outer membrane is a fatty structure. So melphalan, just like any other alkylating agent, then enters the nucleus of the myeloma cell, where it binds DNA and damages DNA, which leads to cell death downstream. So on the left here, I just have a cartoon here of the Flufenamide structure here. Again, there's a small peptide that's linked to melphalan. I'm going to show you just a few kind of laboratory studies, kind of showing this effect of, this peptide drug conjugate, paradigm. So on the right here, what I have is, myeloma cell lines that have basically been treated in Petri dishes in the laboratory with either melflufen or melphalan, traditional melphalan, or melflufen that has been modified such that the aminopeptidases inside the myeloma cells cannot cut it and liberate that free melphalan. And what you can see here, so this IC50 means you're inhibiting 50% of the myeloma cells at that particular drug concentration. And what you can see here on the bar graphs is that the dose of melflufen that is required to inhibit 50% of the myeloma cells is far lower, in fact, 50-fold lower than regular old melphalan. And if you get rid of that, cleavable peptide bond, melflufen performs no better than regular old melphalan, which suggests that this kind of lipophilic nature and then cutting by the aminopeptidases inside the myeloma cell is actually important. This is some more laboratory data. This is mouse models of multiple myeloma. So they took human myeloma cell lines and engrafted them into mice, and they were either treated with control or placebo, Melphalan Flufenamide, or just regular old melphalan. And then they watched the size of the myeloma tumors grow over the course of time. So as those lines go up, that's myeloma tumor growth in those myelomas, in those mice, I'm sorry. And what you can see in the orange line here, the Melphalan Flufenamide treated mice actually had a slower growth of those myeloma tumors than those that were treated with just regular old melphalan at equal doses or placebo. And when you look at overall survival here on the right of the mice, those that were treated with Melphalan Flufenamide or melflufen lived longer. There's a couple of also other kind of interesting preclinical data or translational data that I want to bring to your attention. So one of the reasons why we think, this peptide drug conjugate paradigm is important is that aminopeptidases, which are present in all cells, are overexpressed in cancer cells, and that includes multiple myeloma. And one of the reasons why it's thought that, at least in part, this is felt to be a more targeted alkylating agent than, say, for example, cyclophosphamide or melphalan, is that there is a high level of aminopeptidases in cancer cells like myeloma cells relative to normal tissues. And another thing that's fairly interesting, if you look at the expression of a couple of aminopeptidases in myelomas, specifically LAP3 and TPP2, what you can see is overall survival for myeloma patients whose myeloma expresses low levels of these two aminopeptidases, their survival is better than for those who have high levels of these two aminopeptidases. Now, whether treating patients with high levels of these aminopeptidases with a drug like Melphalan Flufenamide would overcome this negative impact on overall survival remains to be seen. The other interesting thing here is on the right-hand side of the slide. So again, this is just patient samples, myeloma patient samples that are being treated in the laboratory in Petri dishes with a variety of different drugs, including Melphalan, selinexor, bortezomib or Velcade is the other name for it. And interestingly, they looked at both newly diagnosed patient samples as well as relapsed refractory myeloma patients. And interestingly, aminopeptidase levels actually rise with successive relapses of myeloma. So the concentration of melflufen that was required to inhibit 50% of the myeloma cells in the relapse samples was far lower than what was required in the newly diagnosed samples, whereas that kind of differentiation really isn't seen with regular old melphalan or with selinexor or with bortezomib, suggesting that it might be well positioned to work particularly well in patients with relapsed refractory disease. So the first phase 1/2 study was something called O12M1. So this was a study looking at Melphalan Flufenamide in relapsed refractory multiple myeloma patients. There were 23 patients that were treated in the phase 1 portion of the protocol. To make a long story short, a dose of 40 milligrams of Melphalan Flufenamide administered once every 4 weeks with a weekly dose of dexamethasone was considered the optimal dose and schedule for moving forward to phase 2. The phase 2 portion of the study had 58 patients in total. Again, they received Melphalan Flufenamide 40 milligrams IV through a central line once every 4 weeks with a 40 milligram dose of weekly dexamethasone, 20 milligrams for those patients that were over the age of 75. And the primary endpoint of the phase 2 portion of this trial was overall response rate. So if you look at the combination cohort of 45 patients, they've received 4 median prior lines of therapy. A fair number of folks had high-risk cytogenetic features of their myeloma, 44%, and about 2/3 of the patients are what we call double refractory, which means that they had myeloma that had become resistant to a proteasome inhibitor, at least one proteasome inhibitor, and at least one immunomodulatory drug. And what you can see here in the combination cohort of 45 patients, this is melflufen and dexamethasone, the overall response rate was 31%. So about 3 out of 10 patients have at least a 50% knockdown in disease burden. If you look at clinical benefit rate, which accounts for patients who've had at least a 25% reduction in their M spike, for example, that went up to close to 50%. Interestingly, although this is just a small number of patients, 13, the response rates to melflufen alone without the dexamethasone were far lower, suggesting that the dexamethasone may be important here. Median progression-free and overall survival for these 45 patients was 5.7 and 20.7 months. And interestingly, although there was only a small number of patients with melphalan refractory disease, specifically 9, 44% of those patients actually responded to melflufen. So the Horizon study was the registrational phase 2 trial that led to accelerated approval of this agent by the FDA. So this was a single arm phase 2 study that took patients who had relapsed refractory multiple myeloma. They had to have disease that was refractory to pomalidomide or Pomalyst and an anti-CD38 antibody, whether that was daratumumab or Darzalex or isatuximab or Sarclisa. They had to have had at least 2 prior lines of myeloma therapy. They had to have been exposed to a proteasome inhibitor in the past, as well as an immunomodulatory drug. The melflufen and dexamethasone was given in the exact same manner as I said with the other study, and patients were allowed to stay on therapy until disease progression or the development of unacceptable side effects primary endpoint for the study, like many of those in the accelerated approval scenario, was overall response rate. So this is the baseline characteristics of the patients, and it's broken down by all the patients treated on the study, which is 157 myeloma patients, and those that had what we call triple class refractory disease, specifically disease that had become refractory to a CD38 antibody, a proteasome inhibitor, as well as an immunomodulatory drug. High-risk cytogenetic patients were well represented. Over a third of the patients had high-risk cytogenetics. About a quarter to a third of patients had stage 3 disease. They actually had a fairly high number of patients with extramedullary myeloma. This is myeloma that had grown outside of the bone marrow. Median prior lines of therapy was 5, so these are heavily pretreated patients, and they were highly refractory to previous therapies, including 80% of patients being refractory to CD38 antibodies, 90% of patients being refractory to pomalidomide, and 92% of patients being refractory to proteasome inhibition. So the overall response rate for all comers was 29%. When you focus on the triple refractory patients, it was 26%. Again, when you kind of expand it out to those patients who had more modest, clinical benefit, at least a 25% reduction in their M spike, or what we call clinical benefit rate, 45% for all patients on the trial, close to 40% for those with triple refractory disease. So, about, 3 out of 10 patients, again, with at least a 50% reduction in disease burden with this particular treatment, 45% of patients with at least a 25% reduction in disease burden. The response rate, perhaps not surprisingly, drops a bit when you look specifically at the alkylator refractory disease patients. These are folks that had prior refractoriness to cyclophosphamide, melphalan or bendamustine. It was 21%, so there is some degree of cross-resistance, but it's not complete. And interestingly, those patients who had extramedullary myeloma, in other words, myeloma growing outside of bone, the response rate was close to 25%. So about a quarter of patients who have very difficult to treat disease were able to respond. And if you look at the figure on the right here, a number of these patients are actually responding for a fairly long duration of time. And it'll be interesting to see how that plays out with longer follow-up. When you look at median progression-free survival, it was a little over 4 months. That doesn't sound great, but in this patient population, highly reasonable and actually longer than what we saw with belantamab mafodotin, as well as selinexor and dexamethasone when they became FDA approved. And then when you look at the overall survival rate, it's just a little bit under a year. So certainly we definitely need to make some progress from here. As far as side effects are concerned, they were primarily related to blood counts. So low neutrophils or neutropenia was seen in the vast majority of patients, and it was often high grade, in other words, grade 3 or grade 4 in severity. Similarly, low platelets was a very common side effect, and it oftentimes was high grade. So patients with not so robust counts may not be a great candidate for this type of therapy, and the counts definitely need to be watched and supported. The non-hematologic side effects, like the fatigue and the gastrointestinal side effects, while present, they weren't nearly as common, and the overwhelming majority of them were more mild to moderate in severity rather than these more high-grade side effects that we see with the blood counts. So at ASH this past year, the ANCHOR study, or at least the initial results of the ANCHOR study, were presented by Dr. Osio. I'm just going to focus on the combination of Melphalan Flufenamide and Dex with daratumumab, simply because they had 33 patients, which was a little higher. These were patients that were not heavily pretreated. They had had 2 prior lines of therapy, but again, high-risk cytogenetics were well represented. The myelomas in this case were not as refractory to therapy when you look at the numbers of patients who had double refractory disease. In other words, refractoriness to a proteasome inhibitor and an immunomodulatory drug, it was about a third of the patients. So going over here to the right of this table, so there were a number of patients that received a 30 milligram dose of melflufen with daratumumab and dexamethasone, but more patients who got the standard 40 milligrams of melflufen with their daratumumab and dexamethasone. So a total of 33 patients. Overall response rate was a very impressive 73%, which you could argue is higher than what one would have expected with melflufen and dexamethasone alone, recognizing this as a less heavily pretreated patient population, and certainly higher than you would expect to see with single agent daratumumab. The median duration of response was a little over a year, median progression-free survival similarly close to 13 months. So this is impressive, but certainly we need longer follow-up. So this is the clinical development plan for Melphalan Flufenamide. I'm not going to go into too much detail here. We talked about some of these studies. There are a couple of phase 3 studies that are ongoing. So the OCEAN trial is looking at melflufen dexamethasone versus pomalistin and dexamethasone for patients with relapsed multiple myeloma. There's the Lighthouse trial that's looking at Daradex versus melflufen Daradex in relapsed multiple myeloma. There's a study looking at melflufen safety and clearance in patients with kidney disease. There's a study that's looking at melflufen dexamethasone in amyloidosis. There's also a study looking at the safety of administering melflufen through a peripheral IV as opposed to a central IV, such as a port, for example. Right now, it's only able to be given through a port or some other kind of central access. So to conclude, Melphalan Flufenamide represents a novel alkylator for the treatment of relapsed refractory multiple myeloma. It has clinical activity in heavily pretreated patients. The triplet therapy data from the ANCHOR study are promising, but small numbers of patients have been treated to date. We don't know what the optimal sequencing of this drug is going to be with other therapeutics in the same space. For example, selinexor, dexamethasone, belantamab, mafodotin, and ide-cel, which we'll talk about in a moment. Again, the blood count side effects are common and often high grade. So I would argue that an ideal patient would be someone who does not have alkylating agent refractory disease and has robust counts. Non-hematologic side effects are less common and often low grade, which may kind of speak to that more preferential activation of the drug in myeloma cells as opposed to other non-myeloma tissues in the body. Importantly, we don't know whether Melphalan Flufenamide truly is a best-in-class agent. That will require a head-to-head study, which a lot of us in the myeloma community very much would welcome. And with that, I will end. Thank you.